supplement combined with another supplement that became a medication.
Yeah.
But I thought supplements and medicines were totally different. And if you go and, let's say you walk into the average family medicine office, they're going to tell you, oh, you don't need to worry about supplements. They're not going to do anything for you. TUDCA, which you made a fantastic post with our friend Lucas about recently, because really in an interesting turn of events, there was a supplement combined with another supplement that became a medication.
Yeah.
But I thought supplements and medicines were totally different. And if you go and, let's say you walk into the average family medicine office, they're going to tell you, oh, you don't need to worry about supplements. They're not going to do anything for you. But here we had a FDA approval for a serious neurodegenerative condition between TUDCA and sodium phenylbutyrate, if I recall correctly.
Yeah, so the combination of the two was approved for ALS. So I guess if there's anybody with ALS that was previously on both TUDCA and sodium phenylbutyrate, props to them. It's not a cure-all, but it certainly does help. There's a lot of various benefits of TUDCA. TUDCA is very similar to UDCA, which is also known as ursodiol. The U in ursodiol is the U in TUDCA as well. And ursa is the root word for bear. They found it in, I believe, the bile of the bear. And it's part of the reason why they can have so much they can eat a lot of things that are hepatotoxic, and the liver of the bear itself is very toxic with fat-soluble vitamins. But basically, it's a better version of a bile acid, and it has a lot of benefits, not just with digestion and then the gastrointestinal system, but also inside the cell as well.
I guess you could say the bear that takes in something liver toxic, they barely feel it.
Yeah, they barely feel it. Good candidates for this: high bile acids, high uric acid, someone with cholestasis. So there's the high bile acids. Someone with potentially a lot of biliary stasis or biliary dyskinesia, that would make sense. Sometimes very estrogen dominant states that could potentially help. So there's a lot of potential cases of people that are predisposed to ALS that could be reasonable as well.
And if you look at some of the population level, like who is having gallbladder issues and gallstones, you can kind of get a sense of who would be good candidates for this. So women in middle age, women who are overweight, women taking oral contraceptives or in a high estrogen state would all seem to be good candidates. And interestingly, as of late, there's a medication that is being used by a lot of these women for weight loss. And how could weight loss possibly be harmful for someone like that, Kyle?
Yeah, more intrahepatic, basically biliary sludge building up and more gallstones. Now there's actually a warning for semaglutide, which is a GLP-1, for gallstones and gallbladder attacks. So it is not uncommon that I prescribe the ursodiol or the UDCA version of this if they are at high risk, and not just females as well, men with estrogen dominance as well, that are at risk of having that build up and back up in the biliary system and having to get their gallbladder out.
Yeah, so a good history and a good family history is very important whenever you're treating even something where it's just like, oh, weight loss, that's a no-brainer. Let's get this person more metabolically healthy. So if you are an individual who is using semaglutide for weight loss, the speed of the weight loss can also affect how often you or how likely you are to experience this sort of gallbladder sludge or gallstones. So if you lost 20 pounds a month and you're happy and your provider's happy because you're making great progress, you may be at a higher risk for getting a gallstone. So this could be something to consider and discuss with your provider.
Yeah, that's certainly the case. If you're losing weight and you're not doing so with it's not supervised by a healthcare professional, there's a difference between physician supervised and like a program like Slim for Life. Although Slim for Life now prescribes GLP-1, so it's very confusing. But anyway, if that's not the case, that you're having direct oversight with a healthcare provider, then less than about 8 pounds a month is a reasonable goal to shoot for. The slower the better, really.
And people may lose a little bit more the first month with, things like fluid retention or glycogen if they're doing keto. I think we did a podcast on that recently
We did.
as well.
We just did.
But in any case, what about the other part of this new drug for ALS? So the, I guess, sodium butyrate, sodium phenylbutyrate, these things sort of get thrown around. But what is, I guess, why is this an underrated supplement? Because it's been around for a long time. There's a lot of preclinical data, a lot of clinical data. It seems to be like negative calories for mice. Is that the same for humans?
Not quite. Very few rodent studies translate directly into human studies, as our friend Alec McCarthy likes to point out. But there is particularly interesting categories for use. For example, there is a study on pediatric obesity, and they actually looked at the microbiome as an outcome. And a lot of times butyrate is used as it is a postbiotic, so it does affect the gut microbiome. That's well known. And there's a lot of forms of it, but and there's other things other than sodium butyrate that can have an effect. But butyrate can also have an epigenetic effect. I don't believe they studied this within this population group, but it's interesting because you're thinking about the adolescent patient population. We used to think that people with pediatric obesity would grow out of their obesity. But now it looks, after that New England Journal of Medicine study a couple of years ago, that 90% of them kind of grow back into it in the end of their teenage years or when they're 20 or 21. So this is kind of a chance to not only alter their gut microbiome, which is going to change their serotonergic and dopaminergic signaling, but also kind of shift and shuffle their epigenetics while they are being healthy. They, of course, compared it to standard of care, which is diet and exercise. So it seems like a really good idea that while you're implementing lifestyle measures like diet and exercise, shuffle the card deck of their epigenome and try to have as many positive genes turned on as possible.
Right, because we know that if someone was, obese or is obese during adolescence, that the deck is sort of stacked against them. You hear this, conversation about genetics and environment as being, 100% causal of obesity. And I guess you could also make the argument that genetics and environment is 100% causal of everything, because that's really the interactions that are occurring there. But there are, this is a fairly recent study, I think a really promising intervention. And they carried it out over quite a long time period. I believe it was 6 months in this case. And the calorie tracking is always particularly interesting when they look at this. And look at the calorie intake, what they reported, unless they're providing the entirety of the food. And then we know people are still going to snack from time to time. That's why low saturated fat diets work better in the hospital than out of the hospital, even though people are eating the same exact foods.